This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Next we've got Jack Iwashyna from the University of Michigan. We're very fortunate in organising this meeting that he happened to be out in this part of the world on sabbatical, and we were able to cotton on to him pretty quickly as a valuable contributor to our meeting. He's well known for his work in ICU survivorship and long-term outcomes, and he's going to talk to us about the transition from acute to persistent illness.
All right, so how do I not give David's talk again? Not quite as well. It's an excellent talk. It might actually be better than mine. Someplace that's really good at rehab, so that would potentially wean patients where the docs aren't constantly being distracted by whatever catastrophe just came out of the OR or just got sent up from the ED. We went from, in 1997, spending about $500 million on them to, by 2006, spending $1.4 billion on them. And once you cross the billion-dollar threshold in American policy, somebody starts doing something clever. And so the first solution, of course, in American policy is, well, let's prospectively pay for them. So let's define the patients who might end up in an LTAC and just put a pot of money on the table for you to care for them, and you can divide that up between the LTAC and the acute ICU however you want. And so the Center for Medicare Services defined chronic critical illness as patients who would eventually be eligible for LTAC. But that didn't seem right either, and moreover, that seemed really key to a very particular part of the US healthcare system, and so unlikely to be speaking about physiologic truth. So we're still working on hopefully getting my slides up. Beautiful. So the next slide is one that's pretty text heavy because it seems important enough. So I'll just try reading it, and you'll listen carefully. So it's our hypothesis that there exists a substantial and growing group of patients who are ICU dependent in the sense that they're unable to live for more than a few days out of intensive care-like services. We will argue that their current problems are driven by their ongoing cascading critical illnesses rather than their original ICU admitting diagnosis. And we suspect they account for a substantial portion of our bed days. And the introspection part, we have little specific expertise at promoting their recovery as opposed to merely continuing their resuscitation. And I think many of us are quite good at the resuscitation continuation. But Ronaldo's insight was, maybe they're not immutably fated to such a limbo, but rather we could improve their care via both improved ICU patient selection and changing the care and communication practices in the ICU if we could define who these patients were. And so what I've had the privilege of working with CORE over the last year to do is to try to define who are these patients. We've been calling them the persistently critically ill. And these are these patients whose reason for being in the ICU is now more related to their ongoing critical illness than their original reason for admission to the ICU. The people for whom past is past and the history is forgotten, and what matters now is their time stuck in the ICU. And we suggest that this is a novel concept in the family of chronic critical illnesses. So there's persistent critical illness, there's kind of whatever the CMS definition of chronic critical illness, medically complex patient. There are diseases with long intrinsic recovery times. Guillain-Barré is sort of the paradigmatic example, right? Somebody who's in the ICU because hopefully their axons are going to get better at some point, and you're just waiting for them. There are people who have prolonged weaning, which is kind of an orthogonal group, and then within the cardiac surgery literature, where things are a little more assembly line-ish, they just define a group of people as having prolonged ICU length of stay. Just if you've been in the ICU for longer than this, then you're clearly off trajectory. And I think it's an empiric question, which of these is useful in any given context and how much overlap there is between them. And so what we've tried to lay out is a work program that asks, how do patients get stuck in the ICU? Can we prevent that from happening? And if it does, what happens to them afterwards? And can we make it better? And so what I'd like to go over in the next few slides and sort of the next minute. At this point, I'm just giving up on the idea that I'm going to do this when we get to the curves part. Sort of the workflow, right, which has begun with trying to articulate an agenda and sort of articulate this concept as to what persistent critical illness might be. Talk about some exploratory empirical work, and then hopefully convene a consensus conference. We'll have the first part of that, sort of an initial small group where we can really yell at each other vigorously. Sorry, we call that robust discussion in Australia. Is that what that is? Sort of in November. Then do some kind of workable group, and then to cast a wide net to make sure we can engage people in what this notion is. Do some validation and think about measuring burdens so you can develop risk scores, both to inform individual clinicians, but then also to help target interventions. So how do we go about doing this? So the first thing we did is, some of you were already part of this. So we did a survey of clinicians from the ANZICS CTG list and got 101 responses, because you guys are awesome. The Society of Critical Care Medicine in the United States, which speaks for all of North America, routinely does surveys and gets response rates of like 50 people. But because Australian and New Zealand ICU docs apparently kick in, you guys did 101. And we asked you kind of what is persistent critical illness, and when you've seen it, what does it look like? And the striking thing was, how many folks responded. About 59 were ICU consultants, 14 were nurses, 11 were dietitians, 10 were research coordinators, and a smattering of other folks. So when I say ICU docs, what I really meant was ICU clinicians, and I apologize for the people in the room who I just briefly abolished their existence of. And we asked, how long does it take for this thing to happen? And you said, on average, about 10 days. And you guessed that about 10% of all ICU patients go on to develop persistent critical illness. But the flip side was there was wide variation. 25% of you said that persistent critical illness happens within 7 days. 25% of you said it takes on average more than 14 days. So there isn't consensus, but there's a range, and there are enough people who felt like it was an intelligible concept that they could answer. We asked you, what are the problems that typically cause persistent critical illness? 90% of you identified patients as having an ongoing need for mechanical ventilation. Only about 60% said you had respiratory insufficiency as the reason for that. The other big ones that jumped out was there was wide consensus that it was respiratory insufficiency, weakness, and delirium were the things that caused this. Then we asked, what's not persistent critical illness? So we asked you, who are the people who can be in the ICU for a long time? And you kind of said the stuff we expected you to say, which made sense, right? So you said, actually the thing you said most commonly wasn't persistent critical illness, was neuromuscular disease, right? So Guillain-Barré. Head trauma and pancreatitis were the other things that took a long time to heal. Then we asked you, what do you think the outcomes are for this? Oh, look at that. Good. Were those head trauma and pancreatitis? I love it. And then we asked you sort of like a few things we knew the answer should be no to, because if you meant the same thing, like very clearly, coming in for a seizure should not take you a long time to still be in the ICU, and nobody said that was persistent critical illness. So we had some nice kind of negative controls. We asked you, how do these people do? And you said, oh God, they do horribly. And particularly interesting, we asked you to distinguish outcomes from people who had persistent critical illness from merely people who you said were stuck in the ICU for a long time. And helpfully, these curves were different. You thought a lot of people died before leaving the hospital. And you thought maybe 15% of people were alive and well at 6 months, which is a fascinating number, right? Because 15% is dismal, but it's not hopeless, right? Many of us, when we asked our spouses out on a date for the first time, had well less than a 10% chance, or at least I certainly did, well less than a 10% chance that beautiful woman was going to say yes to me. But she did, and it worked out. So 15% is a number you can still work for. I didn't do that. Apparently I should move on. We asked you how you thought you did. Remarkably, a few of you thought, even though they almost all did awfully, you still did a pretty good job. But really, that's a pretty big range. You said it's really stressful caring for these people, and most people thought care wasn't very cost effective, which I think, again, kind of gets at our Gestalt sense of who these people were. But of course, we haven't actually figured out how to define them. So then the next thing Ronaldo said was, is there a way we can empirically define them? And what we said was, let's test a hypothesis, right? We can actually formulate this kind of Gestalty concept quantitatively. So if we're right if it's about these cascading critical illnesses, there should be a point in your ICU stay beyond which ICU admission diagnosis and severity of illness in the first 24 hours no longer differentiates patients. It's now about you being in the ICU, not who you were when you came in. Let me skip the next slide in the interest of time and say, so we started going about testing this. The first thing we did is we took the core data and we took Dave's awesome ANZROD score and just divided people up into 3 groups. There's the group who we kind of conceptually all think of ourselves as caring for, those who have sort of a 66 to 100% risk of death when you walk in the ICU. There's that mid-range group who have sort of a 33 to 66% of care risk. And then there's the vast majority of our patients, but the ones who don't actually get us all that excited about, people who had less than a 33% risk of death. And so we binned people based on their presentation severity of illness, and then just looked at those still in the ICU every day, what was their actual risk of death. And what we find is this kind of nice de-differentiation, whereas, as you'd expect, since Dave's risk of death score works pretty well on day 1, people in the highest risk of death are 20 times more likely to die than people in the lowest risk of death on day 1. But it's like 11 times more likely to die among those still in the ICU on day 2. It's like 8 times more likely to die among those who are in the ICU on day 3. And it pretty quickly gets down quite low. It doesn't get down to 1, right? So the people who were sicker on presentation from this composite risk score, which of course includes lots of things like age and comorbidities, are more likely to die than those who were unlikely all the way out. But it's nowhere near as big an issue as it is at the beginning. And then the next thing we did is said, let's divide everything we have in core into 2 bins. Things that were true of you before you hit the ICU door, and things that were true of you once we hit the ICU door. So the things that were true of you beforehand include kind of age, comorbidities, gender, indigenous status, as well as some stuff about like which hospital you're at, whether it's a Monday or a Saturday, because that actually makes a big difference in Australia. And those were what we call the antecedent characteristics. And then we took all the stuff we think of as acute physiology, basically all the stuff from the acute physiology score, as well as stuff that's kind of mostly a marker of how sick you are. So if you've had a cardiac arrest in the last 24 hours, we actually called that an acute issue. Whether you got in as a result of a MET call, that kind of stuff. We called that acute. And then we asked, among the patients who are in the ICU on each day, what's their relative predictive power? So we're just going to do an area under the ROC curve for each day for the 2 different pieces. And what you see is, on day 1, that top green line tells you exactly what we all know. When you first come into the ICU, how sick you are when you first come into the ICU is much more important than your age and sort of those baseline demographics in terms of telling us what's going to go on, what are going to be the outcomes of your ICU stay. But as time goes on, by about ICU day 10, day 11, day 1 gradually ceases to matter as much. And instead what happens is these baseline antecedent characteristics, kind of people's underlying protoplasm, becomes actually more predictive than how sick they were. And you have this, people are no longer as different. And we would suggest that that maybe is when persistent critical illness is occurring, when you're getting that transition to the particular details of your acute presentation not mattering as much. Now, of course, the next thing Ronaldo says to me is, yeah, but go run every damn subgroup that you can find and prove to me that's not possibly real, because that's a pretty nice, pretty graph that actually confirms your hypothesis. And you get a graph that confirms your hypothesis that nicely, your first assumption should be that you jimmied the data in some way that made it work in your favor, right, and that it's wrong. So we divided the world up into people kind of basically tertiles of risk, and looked at each of the tertiles of risk. Now, all of these areas in the ROC curve shift down because when I stratify for tertile of risk, that already controls for a lot of the stuff that used to be in the risk score beforehand. But you still get probably a pretty nice transition, except for maybe in the lowest risk group, where honestly the confidence intervals are so big because nobody's supposed to die in that group that actually using mortality is kind of hard. Then we said, okay, well, if it's around 10 days, let's just look on its face and ask, what are there differences in outcomes? So the first thing is, you can divide the world up, and clearly there's an error in this slide. You'll forgive me. No, there's not. So there are about 750,000 patients in the database, and everybody can then be mutually partitioned into they had an ICU stay of fewer than 10 days or 10 or more days. Among those who get out in fewer than 10 days, about 10% die, because that includes some people who die quite quickly. Among those who take 10 or more days in the ICU, the potentially persistent critically ill group, 25% of them go on to die. Among people who get out of the ICU quickly, 76% get discharged home. Among those who stay in the ICU for 10 or more days, less than half get discharged home. A lot still do, but less than half. And these 52,000 patients who stay for 10 days or more account for a huge number of your bed days. They're only 5% of all the patients, but of course, bed days is just incidence times duration, right? So their prevalence is 33% of all ICU bed days are spent caring for this 5% of your patient admissions who came in. And they go on to account for 15% of all the hospital bed days at all associated with anybody who touches an ICU. I will say, I haven't actually published any of this yet, so people are welcome to grab photos of you. You could not tweet it. That might make my life eventually easier with whatever journal editor I'm trying to get this in with. So that's sort of some interim conclusions, right? That persistent critical illness can be defined, and it's probably not just relabeling currently described syndromes of chronic critical illness. That many Australian and New Zealand clinicians identify consistent features of persistent critical illness and have concerns about the current care and outcomes of these patients. And our test, the persistent critical illness hypothesis, looks like it's supported with an onset somewhere between maybe 8 and 12 days, depending on how exactly you want to count that number. So what do we do next? Well, we go back to sort of this program of research. Articulating the concept, this is part of it, right? Giving it a chance for me to come up here and you guys to robustly discuss back to me some of the concerns. Mary, you're not invited to just ask one of your stupid questions, but the rest of you are welcome to ask me hard questions. We've done some exploratory work. Sorry, Mary hosted us when we were in Adelaide. My daughters routinely say they want to move back to Adelaide to be with Mary as opposed to live in my household. There's a survey, we participated in this survey where, thank you, because some of you in the room did this, and thank you for your tremendous response rates. We've done some work about the onset of chronicity. The time course of complications is sort of the next question, right? A natural hypothesis about the mechanism by which who you were at admission no longer matters is that bad stuff happens to you in the ICU, either iatrogenic or just bad stuff, right? Sepsis is bad and we don't have full control over it. And so a natural next step with CORE is to start exploring the onset of hospital-acquired conditions and do they cluster when we'd expect. And then we've been working hard to basically replicate CORE in the US Department of Veteran Affairs, so that we can run exactly the same analyses in a very different patient population in a different health system and find out if this is a Australia-New Zealand thing or is this something that's maybe truer of physiology more generally. There's a consensus conference that's going on. If people are interested in that process, at some point shoot me an email and we'll find ways to cast a broad net. I think there's lots of room for lots of people's thoughts. And then moving on to do validation. But the point of this is not merely to be an epidemiologic experience, although that's what pays my bills, so I love doing epidemiology. But when we asked you what could we do better, the 101 people took the time to suggest 188 different, almost all of which were actionable suggestions for potential interventions that could improve the care of these patients. And so the goal of this process is really to get a case report form that we could use as an inclusion criteria to relatively quickly move to start testing the stuff that your experiences and those of your colleagues have told us might make their lives better. And we're eager to do that. That's my email address. I also tweet a fair amount, which makes it relatively hypocritical for me to ask you not to tweet my slides. But there you go, I'm an American. I'm happy to take questions if we have time.
Any questions from the floor?
Jack, can I ask a first question? patient's been in ICU coming up to 2 weeks. A few bad things have happened, you know. He wasn't as crisp as we thought he might be when we admitted him. But obviously what I need to know as a clinician is he one of the 40% who's going to go home, or one of the 60% who's going to sort of hang around the hospital for months and months and eventually either die in hospital or limp off, sort of not under his own steam, to some chronic care place. I mean, 40% going home is still pretty good odds, but if, you know, what we need to figure out is a way to find out about who do we invest our resources in all those ICU days and hospital days in, and it's going to have a payoff, and who are the people who are sort of, it's all going to unravel and they're going to do bad. Did your survey give you any clues in that?
So we're not there yet. I've only been here 10 months. So I only got the first 3 papers written so far. So I think actually Shannon Carson's work on the ProVent score, I strongly recommend to you. So if you're willing to wait that long, when you face the question of how do I prognosticate for someone at day 14 or 21 on the vent, it actually works incredibly well for helping to sort out who's going to be alive or dead a year later. Yeah, I feel like I had a longer answer to that, but I think the short answer is Google Shannon Carson ProVent.
Are there any, because you've shown that the sort of chronic, the factors that are there on presentation, that were there, the pre-existing factors, can help determine by day 10 where people are going to be at. Are there things that are more important than others? Is it the comorbidities? Is it the age of the patient? Is it whether they're indigenous, as you mentioned? Have you broken it down to any of those things?
So we have not yet. I can say, as someone who comes from the U.S. and is pretty sensitized to race and ethnicity, I was amazed and really excited that Indigenous actually just refuses to be an independent prognosticator in Australia. So good on you guys, because that's not something the U.S. has achieved. Looking within that more specifically, I don't know we haven't done kind of more specific stuff to break that down. I remember what I was going to say, Tony, which is that one of the things we know is that physicians are very prone to anchoring bias, right? So once we get a diagnosis in our head, we really like it. It's just so much more comfortable than reevaluating it. And so what worries me, and when I think about myself taking care of people who've been in the ICU for 14 days, the ones who came in with a UTI who were supposed to get out, I still think of them as going to do okay. And the ones who came in with a cardiac arrest and who we cooled for 3 days, I still think of it as a bleeding miracle if they get out. But the reality is, and this data would suggest, that I'm prone to very overvalue parts of the presentation history when I'm thinking about prognostication with the families. And so I worry that I'm telling kind of the gestalt I'm using either for implicit or explicit risk benefits might be wrong. And I think it's one of the reasons why what you and David are pushing us towards, which is kind of some dynamic kind of re-updating of our risk scores, is really important, because otherwise the heuristics we use will lead us down the wrong path. Thank you very much.